Welcome to the Clinical Genetics Grand Round today. We have a special guest for Dr. Mark Korson. Actually, in a sense, he's not special to many of our audience here because I think he has been joining us for at least when I joined in 2019. He's been with us every year. So thanks again, Dr. Korson, joining us again for this year. We also have a special guest, and Dr. Korson will introduce later. Very quickly, for many of you already know Dr. Korson, it's no need an introduction, but for those of you who are new, Dr. Korson received his medical training from the University of Toronto, and then he was running metabolic director for the Boston Children's Hospital and the Tufts for quite a number of years. And then he left the academia and then went to the VMP Genetics and be director for the patient education support. He really be very, very active around the kind of North New England area, kind of academy, metabolic academy, and do a lot of teaching and educate the physician and public about rare disease, particular metabolic disease. So that's the significance of the contribution to the community, and that's what we have him today. And with that short introduction, I'll let Dr. Korson introduce the topic, and then all the Maria and Tom and Will, thank you for joining us today. So,
thank you so much. It's always a pleasure to be here this morning. What I'm going to do, though, is first introduce Rare New England's executive director. Rare New England is the organization that hosts the Rare Disease Day Speaker Series in New England. So, Nicole, why don't you kick off this morning?
Sure. Thank you, Dr. Korson. I am going to share my screen. All right. Hi, everyone, and welcome to Rare New England's Rare Disease Day Speaker Series. Again, my name is Nicole, and I'm the Executive Director of Rare New England. Rare New England's mission is to bring together New England families, patients, and providers touched by rare and complex disorders. We offer educational opportunities, create awareness of available resources, and build foundations for support to improve patient quality of life and support the professional needs of healthcare providers. Here we just wanted to show you our Rare Disease Day speaker schedule this season, the different institutions that we have visited, and the different diseases that we have spoken about. Of course, I'd like to start by thanking Yale New Haven Genetics Clinical Grand Rounds for being a part of our program, as well as our patient speakers today, Maria and Tom Rebecki, who will be sharing a little bit of their story living with a rare disease. So I will hand it over to Dr. Korson.
Thank you, Nicole. I'm going to share my screen. All right, so today's topic is Glut-1 deficiency. And this has a neurologic bent, but is thoroughly metabolic. So what is Glut-1 deficiency? In brief, it's a problem with glucose transport into the brain. So the body, there's no problems with glucose transport anywhere else except for the brain. And in Jean-Marie Sodebray's classification of metabolic disorders, which is divided into disorders of intoxication or small molecule disorders associated with intoxicating compounds like ammonia or phenylalanine. There are disorders of energy metabolism, which include mitochondrial disorders where ATP synthesis is restricted, or problems in mobilizing or transporting energy substrates, and then all the other disorders, which include disorders of complex molecules. So these are lysosomal storage diseases, peroxisomal disorders, and so on. And so today's topic are the Glut-1 deficiency falls into disorders of energy metabolism. And the problem is in transporting glucose again, using the Glut-1 transporter or SLC2A1. Now, the symptoms and signs of Glut-1 deficiency are extremely variable. They're variable from patient to patient. Some can have more severe, some can have very mild. And within the same patient, you can get variable symptoms at different times. Paroxysmal, that is intermittent, is the name of the game. And the symptoms can be fluctuant, and some symptoms can go on to become chronic. But why paroxysmal? Well, think of it. If there's an increased need for energy by the brain, then that's when the symptoms are going to come on more significantly. So you can get exercise-induced dystonia or hunger-induced rage. So what are the triggers that particularly limit the glucose need to the brain? Situations of hunger, exercise, illness when metabolic rate is higher, or under physiologic stress, anxiety, excitement, when again, the metabolic needs are higher than usual. And these symptoms may evolve and change over time within the same patient. So in infancy, one can see intermittent involuntary eye movements or aberrant gaze saccades. And that could be the first symptom within the first couple of months of life. Neurologic symptoms are prominent. So often below the 2 years of age, patients develop seizures, which are often resistant to therapy because the thing that the brain needs is a source of energy. Complex movements are also figure prominently in this disorder. So altered tone, dystonia, ataxia, tremor, chorea, and these, again, are not consistent. These can be variable. One can have hypotonia and spasticity, and again, periodic. Most patients exhibit some form of developmental delays, which could be mild or can be severe. And these involve gross motor, fine motor, and speech delays. But then things to think about are also episodic periods of changed mental status, where patients become unusually drowsy for unexpected reasons, or patients later on at night who are sleeping wake up and have disturbed sleep, again, because of problems with glucose getting to the brain. And then episodic rage or behavior changes because patients haven't the energy to control their behavior. Over time, as patients get older, one might see that seizures get better. In other symptoms like neurologic features, they actually might get worse or might get entrenched. If there's not enough energy going around, patients develop a sort of an exercise intolerance, but it's not an exercise intolerance in the brain. It's sort of a fatigue. It's a brain fatigue. Patients exhibit headaches, have difficulty focusing, problems with mood disturbances like anxiety. And if the chronic deprivation of glucose to the brain is chronic and severe, then acquired microcephaly. Unlike other metabolic disorders, which are generally autosomal recessive, Glut-1 deficiency is dominant, and most mutations are spontaneous. But if one does gene testing for SLC2A1, in about 10% of cases, you might not actually find the mutation. And so then diagnosis may be a little bit tricky, but by no means impossible, because one can look at the biochemistry. So the blood glucose is going to be normal. But if one measures CSF glucose, then in virtually all cases, it's going to be less than 60 milligrams per deciliter, 90% less than 40. But of note, the CSF lactate is also low. And that's something that we don't think about. We think about elevated lactates. Mitochondrial disease, we often look for elevated blood and CSF lactates. But in this case, you're looking for low, which makes sense because once glucose gets transported into the brain, it goes through glycolysis, and it will, at the end of glycolysis, you get to pyruvate, and the metabolites either enter oxidative phosphorylation or go towards lactate. But if there isn't much glucose coming into the pathway, you're going to generate less lactate as well. In situations where you might have difficulty in confirming a diagnosis, then doing red blood cell studies, looking at glucose uptake is a way of confirming the diagnosis metabolically. And in general, in severe cases, the glucose transport is diminished by up to 70%. The physiology dictates the treatment. So if glucose, we can't depend on glucose to get across the blood-brain barrier and into the central nervous system, then by providing fat as an alternate source of energy, fat enters beyond pyruvate, and then that feeds oxidative phosphorylation. So a high-fat, low-carbohydrate or ketogenic diet makes a difference. Although some of these have been studied, and they may not have a particular impact, when part of an overall ketogenic diet, a high-fat diet, medium-chain triglycerides, triheptanoin can be helpful. However, be careful, because these patients have seizures, but some of the anticonvulsants can not only not be helpful, they can actually make things worse. For example, phenobarb, valproate can actually inhibit Glut-1 transport and therefore aggravate or exacerbate the symptoms. Valproate interferes with fatty acid oxidation routinely. And so if you're depending on fatty acid oxidation to generate ketones, you don't want to mess that up. Alpha lipoic acid, which is a good antioxidant, happens to enhance Glut-4 and Glut-1 transport. And of course, these patients need support with physical, occupational, and speech therapy, not to mention the families need support as well, given that this is a chronic disease. So at this point, I just want to mention that the Glut-1 Deficiency Foundation helped establish this osmosis video, which if you go to the Glut-1 Foundation website, you can actually click it there. It's a nice 6-minute overview that serves as a good teaching tool. But it is my pleasure at this point to introduce Tom and Maria Rebecki. Tom is an emergency room physician, and Maria is a registered nurse, and they are parents of Dominic. Dominic is their son with Glut-1 deficiency, and theirs is an important story to hear. Thank you so much, Tom and Maria, for joining us this morning.
It's our pleasure to be here. We're gonna, if you take your slide down, Dr. Korson, we're gonna put some slides up and go through a bit of Dominic's story. I would say there's 2 parts of that story. One is before diagnosis and one is after diagnosis, and some of the physical exam characteristics that you described, Dr. Korson. We have some videos, brief videos that show that you know what Dominic was experiencing. The other thing that I will say is that as Dr. Korson kind of lays out the symptomatology and the need for energy, it all seems kind of very clear because we're living in it and walking in those shoes every day. But looking back, these, you know, there were lots of what I like to say breadcrumbs in Dominic's story. Sometimes looking back, they seem like they were croutons and you know, bigger than breadcrumbs. And then we finally, you know, thankfully came across the right clinician to kind of put things together, and we'll tell that story here briefly. You have to click on this. There you go.
All right. So being a part of the rare disease community was definitely not a part of our plan, but here we are. And with that, you know, I've learned a lot about the challenges of rare diseases, and just by being immersed into the community. And I am on the board of directors for the Glut-1 Deficiency Foundation, which is the advocacy group, and Tom is one of the science advisors. So obviously, one of the biggest challenges with rare diseases is the number of rare diseases. So With that, there is not a ton of research that is happening, limiting treatment options for most of the rare diseases. Glut-1 deficiency is one of the luckier ones. We do have a treatment. So treatment options are limited. And then I think access to genetic testing has gotten easier since our son was diagnosed 9 years ago, but still can be a challenge for people, and specialists to care for these patients are not as numerous as we would like to see. So yes, we have a local doctor that helps us out, but our nearest specialist is in Dallas, and thereafter in Germany. So, you know, it's really hard to get very specific care for our son. So we are the advocates, and we kind of become the experts. And this is the case in most rare diseases. But the benefit to diagnosis is families have a new direction and hope, and they have answers. And in general, they feel less lost. And they can hopefully pursue that happiness with connecting with other families who share similar stories to theirs.
Yeah, I like to say families and the patients who have a rare disease are welcomed into a club that they don't want to be a part of, right? So that's a little bit of the perspective, but this is a lifelong condition. Obviously, it's a chronic condition, and so we have to embrace the disease and the treatment with our son Dominic. And just a brief kind of word, not only for the Glut-1 Deficiency Foundation, through our experiences with Dominic's rare disease, it seems like many of these very rare diseases have family foundations. And so I think it's a great place to kind of direct your families and your patients when you're making those diagnoses, because it's been a big, kind of a huge help and essentially a game changer for us.
So Dominic is 12 years old now. He was diagnosed right around his 3rd birthday. So I'll just start out by telling his story. So Dominic was born a normal, healthy baby, full term, no problems after birth, ate normal, slept normal, everything seemed fine. I nursed him, and he ate, his normal every 1 to 2.5 hours until he was about 3 months old. And I was trying to spread out feedings a little bit, and we would start to be introducing some baby food soon thereafter. And as we were doing this, we started noticing that Dominic would have these weird eye movements where his eyes would go in multiple directions and his head would kind of follow the same eye direction. And I will show you a video. And this is a video of the aberrant gaze saccades.
It's all right. It's all right. Just stay there, okay? It's all right, buddy. It's all right, buddy. It's all right. It's all right.
So you see some lip smacking there. There's some kind of similarity with some seizures, and then we have another video as well.
You good boy? Give him a lip smack there. See that? It's okay.
So kind of seizure-like, but Dominic's a little bit older in that video. And so when we saw this activity, the first video that we saw, we knew obviously something was wrong. We're both healthcare providers. And so we kind of started, kind of down the path, which we kind of knew a little bit about, right? Pediatrician, neurologist, lots of testing. And that's actually exactly what happened. This one.
And so with that testing, so this happened multiple times, and finally we said, okay, we need to see a neurologist. And Dominic had a 5-day at-home EEG, which was negative. To this day, he's never had a positive EEG, even though he did have 1 grand mal seizure. And then he's had a lot of these other, what we call episodes. And the reason we call them episodes is because he's never had a positive EEG. He also had a negative MRI. There were no deformities. He's actually had 2 of them. And so what was decided is that we were going to try him on an anti-epileptic medication. and kind of see how things went. And, sometimes you think maybe things are working, but, looking back, I don't think that medication made a difference. We then had added a second medication with the increase in eye movements and other symptoms, and with the grand mal seizure. And again, you think maybe they're working, but the episodes definitely continued. We didn't notice a whole lot of a difference. And then, so as things were going on, at the age of 1, Dominic was not attempting to crawl, not walking. He was not really pulling himself up very well, if at all. He was not babbling. He just always seemed kind of out of it, like he wasn't there, like he was always tired. He wasn't playing or entertaining himself. Loud noises bothered him. He didn't like music, which, really bothered me a lot. I started thinking, is this autism in some way? And, Tom and I are very diligent parents, and, we're in the healthcare field and we watch everything. And, there wasn't that much concern from the neurologist or pediatrician. They said, well, it could have something to do with the epilepsy that he's diagnosed with, or it could just be that he's developing at later stage, a later stage in his life. Nonetheless, we decided to get started with some earlier intervention.
Yeah, you can see the picture on the bottom there. Dominic often looked like a prize fighter, or not so good of a fighter, because he was wrangling with the floor often, right, and trying to walk. And we'll show some videos of his ataxia here, but the hematoma that he has on his head there was pretty typical in his toddler years.
And then as time went on, as Dr. Korson had shared with you, that a lot of the symptoms start evolving into different symptoms. So the eye movements stopped. And as he began to walk, at around 22 months, he was attempting to walk. He had some pretty obvious ataxia. He had episodes of alternating hemiplegia. Like Tom said, multiple falls. His developmental delays were worsening. I'll get into that in a little bit. And then his episodes of additional ataxia, stamina, one-sided weakness, and whole body paralysis were getting worse. And what would happen is, Dominic would learn, say, how to crawl up the steps. And then he would have one of these, whole body paralysis episodes, and he would not be able to walk up the steps the next day or crawl up the steps the next day. So he was having a regression of milestones.
On a good day, you'll see Dominic here. This is him at 2.5, running down the hallway of a hotel, or kind of stumbling down the hallway of a hotel, kind of with a kind of a wide-based ataxic gait. And that was probably a good day for Dominic at 2.5.
And so we were desperate for answers, especially with the regression of milestones. I knew in my heart that, regression is never, ever a good sign, and that this was more than epilepsy. We were desperate for answers. We were, at our neurologist frequently. He had ended up ordering some metabolic testing, which Dominic had some abnormal levels, but those levels never really correlated with any specific rare disease. We brought him to a developmental pediatrician. We were bringing him to PT, OT, speech. We were doing everything possible.
And there was minimal improvement and lots of regression when he had one of these episodes. I want to kind of point out this middle picture, which is kind of interesting. What Dr. Korson said, this is a lack of energy to the brain. So he looks very happy in the middle picture here, but you can see some things around his mouth, and those are remnants of Oreo cookies. So 5 minutes before this picture, 10 minutes before this picture, he was having a complete meltdown, uncontrollable, crying, angry, swinging. And, I brought him outside. We were visiting some friends. I put him in his chair and I fed him Oreo cookies, and this was him 5 minutes later. Again, one of those breadcrumbs or croutons that I like to talk about that we were discussing with its clinicians, but I'm a clinician as well. We didn't put it together. You know, it's very easy to look back and Monday morning quarterback this, but that was an exact example of what was going on.
And so, you know, looking at the big picture is sometimes not easy. And so, like I said, we were at the neurologist and at our doctors all the time. And finally, our neurologist came to us and said, listen, I think we need to have a team meeting. You know, we need to kind of figure this out. I'm going to have a metabolic specialist come in and the developmental specialist come in, and we're all going to talk. And I thought, this is great. This is exactly what we need, because I can't figure this out. And, you know, this is impacting our everyday life. This is not just something that's happening once a week or once a month. You know, our family and my child is suffering every day with these symptoms, and nothing is helping. So I thought this was really, really positive. And during that meeting, we were told that, you know, we should stop searching for answers and accept the way things are. And with this, our lives, you know, will probably be easier once we accept that. And I was heartbroken because I was not ready to accept it, because I felt like something was wrong. And I'll go back to the regression of milestones. I'm an ER nurse. I've seen thousands of people have seizures, and 99.9% of the time they have a seizure, they come in and 2 hours later, they leave at their baseline. And if they can't walk after their seizure, that is a big concern, right? And this was every single episode for my son. So, you know, it just didn't settle in that we should accept the way things are. So Tom will help me with this story, but this one always gets me a little emotional. You know, Dominic was 2.5, and we brought him to his pediatrician appointment. And this is one of the doctors we hadn't really seen before, because we're in a practice where you can see a lot of different pediatricians. And it was basically a therapy appointment for me and not an appointment for my son. And I was crying and upset, and I was telling our doctor all of, you know, everything that was going on. And I was just at a loss, especially after the appointment with our neurologist. And he said, Maria, he's like, has anybody considered genetic testing? You know, just looking at the big picture is that Dominic has some really, really different, weird symptoms since he first started having them, and they've kind of changed over time. And maybe this is something in the rare disease world. And I sat back and I'm like, I can't believe that I haven't thought of this. And, you know, to this day, I credit Dr. Weber for saving my son's life, right? His quality of life.
Yeah, and Jason, Dr. Weber was awesome, and he did his job exactly right, which is, you know, he's looking at the entire field, where we were taking Dominic to people that were running single plays, right, keeping with the football analogies. And so right after, you know, we're fortunate to be in the shadows of Children's Hospital Philadelphia, just about 20 minutes away. And so we set up some genetic testing, or a genetic test, which happened, I think, in May. Right before, you know, Dominic was 2 years plus at that point. And then we got a phone call from them that our August appointment needed to be moved up closer to around, you know, right after July 4th. And that's when we met with them and got the diagnosis. And, you know, immediately, you know, we're relieved and devastated and everything else at the same time, but we were given, you know, kind of lots of hope from the geneticists related to the treatment, which is providing energy in a different format than glucose, and obviously got immediately connected with the largest ketogenic diet program in the country, which was being run out of, you know, the neurology department, pediatric neurology department at CHOP. And you're seeing pictures here of Dominic's hospitalization, which was a Monday to Friday hospitalization, induction into ketosis. And those pictures were, I think 9/9 was a Tuesday, so or a Wednesday, so a day or two after ketosis. You can see some of those previous pictures where Dominic looked like he was in a fog. That was the first thing we saw that was different. He didn't start speaking immediately. Like, Dominic probably had 3 to 5 words that you might understand when he was admitted, for his induction into ketosis. And that didn't change. It just improved dramatically faster than it had. And so, introduction to the ketogenic diet, which was obviously a life-changing event for us, but very impactful for Dominic. And, those developmental delays, although he still has all of them, were blunted by the induction, his induction in the ketosis and our persistence with the ketogenic diet now coming up on 9 years.
So, miracles can happen. And honestly, this was probably one of the most amazing miracles that I had seen, not just because it's my son, but how fast things changed for him once he had appropriate energy to the brain. So these blocks that you see here on the left, they were kind of sitting in the corner of his room. He had never played with them in his life. And 2 days after we got home from the hospital from initiation onto the keto diet, my daughter ran downstairs screaming. I thought it was some emergency, and she said, "You're not going to believe it. Dominic made a castle out of blocks." And I said, "What?" He had never played with them. And I went upstairs and I found that he had the clarity to finally be able to put it together. So it's not like it wasn't in his brain. He just could not execute on those functions.
Yeah, that focus, that fog kind of was lifted. So,
let me get back to that. So this is Dominic. I told you couldn't walk upstairs. This is the first time he was walking up steps independently on his own without crawling. And so this was probably 3 months after. Again, a miracle for us. And so looking back, again, it's easy to look back, but when you're going through it, you just don't always pick up all the things. So symptoms related to hunger, grazing for food constantly. He was always awake and aware during episodes, whether it was the eye episodes, whether it was the full body paralysis, the alternating hemiplegia. He had episodic symptoms. He had ataxia and alternating hemiplegia, which there aren't very many diseases that cause that. And then, of course, the regression of milestones.
So Dr. Korson went over this. One of the things in getting involved with the foundation that I realized, and again, I'm a physician and I see, diabetic patients all the time, right? Patients who are diabetics, and there's always a spectrum of disease. And we didn't have that perspective until we kind of got involved with the foundation and started interacting with other families and patients of children with the same rare disease. And so just like every disease that we know about, there is a spectrum, and we're thankful that Dominic is probably on the rare, the less severe end of the disease spectrum compared to others that we see when we get together with other families or the foundation meeting, which happens every other year. And so I think Dr. Korson also touched on some of this. The seizures tend to, kind of show themselves in early childhood, and then they tend to go away and are replaced with things like ataxia, and the developmental delays are kind of consistent. And the things that we deal with, inclusive of last night, right? The diet, although it is, it's a very challenging diet, especially in the beginning, that's old hat for us. Managing Dominic's developmental delays are the things that incorporate our everyday life, doing homework with him, getting him the right services at school and things like that. So as we talked about already, which is, replacing that glucose with some other energy form, and most kids with Glut-1 deficiency will respond to this. And it obviously presents challenges not only for the preparers of those meals, but the children who have to eat them. And this is a very rare disease. There's around 1,000 that are identified probably worldwide. We suspect that number is a lot higher based on the number of children with epilepsy.
And I'll just go back to diagnosis is life-changing at no matter what age. I met a 75-year-old woman who had been diagnosed at 72. And the only reason that she was diagnosed was because her granddaughter, who had symptoms that were much more severe than her, was diagnosed as an infant. And then she went back and said, you know what, I think this is maybe what I have. And she had suffered her whole life with movement disorders. And she was at the point where she was no longer mobile. She could not walk, even with a walker. She was wheelchair bound. She started the ketogenic diet at 72 years old. And within 6 months, she was able to walk with a walker. So it's never, ever too late to replace that fuel in the brain.
So just some of the things that Dr. Korson mentioned, and some of the things that you heard from our presentation. Your patients don't expect you to know everything, but listening and trying to identify those breadcrumbs and helping your families navigate the healthcare system. We're two people in the healthcare system already. It's just really hard. It's hard to hear a diagnosis. It's hard to navigate. So be aware of that when you're talking to your patients. That's one of the things that we talk about. Life after diagnosis has been great. We've traveled many places around the world. Dominic is a very unique and loving child. And, he's, one of the things that he has, as well as many kids with Glut-1, is that they're very gregarious. And we think that that's a big part of him overcoming his developmental delays, actually. There's one last thing that I want to show you, which is the child. This is probably Dominic at 5 or 6, the child who had, and we'll leave you with this, the child who had 3 words going into the ketogenic diet.
Good. I didn't go outside, but I ate inside, and we were gonna make a book, but we couldn't finish it. So we just went to the library, and we couldn't go outside, so we just stayed inside.
And then the video on the right, to make moms nervous, he was able to do this around the same age. So
Yeah, and that didn't come without hard work. So, again, PT and speech and OT, they didn't end, and they still continue to this day. There's also this talk kind of in the community, because we're getting a lot more adult patients now, because children do grow up to be adults, and they still need continued therapies. So it's not easy. There's still challenges with Glut-1, even on keto. Dominic struggles with stamina, heat intolerance. Very rarely does he have ataxia, but he does have an episode, especially after we fly, every once in a while. He has learning disabilities, and that, as Tom said, is probably our biggest challenge right now. He has some fine motor delays, difficulty typing, fatigues real quick with writing. He has some gross motor delays, but if you were just to see him individually, you would not notice it. But if you were to see him next to a typical 12-year-old, you would definitely see the difference. Keto will be lifelong for him. He's been going at it for almost 10 years. I can't believe that I'm even saying that. It's just incredible to me. It's not without challenge, but we've been able to do it. Therapies are lifelong. We worry about independence for him, and especially that transition into adulthood. Not only, just with, say driving and the learning disabilities, but with the ketogenic diet. It is not an easy diet to do, alone. We kind of tag team most of the diet for him. So, and just quickly, there's, a lot of research coming together, especially in the last few years. We have a biorepository collection at 2 different facilities. There's a brain bank that was initiated, patient registries, natural history study. The roles of glucose are, being discussed among our researchers now, in that maybe this is a glycogen storage disease, and they're finding that there is a role of fructose, not fructose, but fructose and lactate. And so we're finding that it's a lot more complicated than we ever thought that it was. Again, there's no treatment other than the ketogenic diet, but there is research on drug screenings for repurposing drugs, lactate studies, blood transfusions, gene therapy, and other forms of the ketogenic diet. So introducing other types of oils. And the last picture, this is the picture from our last Glut-1 deficiency conference. This is all the families and patients that attended in San Diego this past summer.
And in that picture, you will see 2 physicians that are advocates and friends of the Glut-1 Foundation and rare disease community. We mentioned Dallas. There's a physician who probably cares for the biggest cohort of Glut-1 patients, Juan Pascual, UT Southwestern, and then Jörg Klepper. I'm not sure which university in Germany he's associated with. They're both in this picture with all the children, and they are two very individual, unique pediatric neurologists who have taken a special interest in Glut-1 and the foundation, and we owe them so much. So I wanted to mention their names.
So I will stop my share. And thank you, Dr. Korson and Rare New England for this opportunity, and Yale as well.
Well, thank you. That's your personal and professional insights are unique and are especially make your presentation particularly powerful. I invite questions from the group for Tom and Maria. I will say that your one of your final comments that Glut-1 deficiency is much more complex than you thought. Well, welcome to the metabolic world, where we thought, diseases, you just look at this pathway and you see a block and you fix this and you fix that, and it's never like that. So why should Glut-1 deficiency be any different? One point though, it's what frequently happens in the newborn ICU and in any age is the confusion of seizures and movement disorders, and that they can resemble each other. And so sometimes, unusual movements, rhythmic movements are perceived as seizures, and they might be deep seizures and that don't get identified on EEG, but sometimes they're really just, they're indicators of a movement problem. In Glut-1, it's, both are, these patients are at risk for both. Question from, all right. So one question, how does Dominic participate in his own care now in terms of his diet?
So he makes a lot of choices for himself. I've kind of had to step back and allow him to do that. He does weigh some of his food. Actually, this morning, Tom said that he made his own lunch. He took the initiative to go in the fridge and get his beef jerky and his cheese stick and, get his heavy cream out. And he doesn't weigh his heavy cream and oil out independently, but he can do it. We just kind of have to stand there and really watch him. So he's starting, but it's a tough transition because, if things aren't perfect and he comes out of ketosis, then he gets sick and has symptoms.
He's made it generally pretty easy where he's very, he drinks heavy cream and oil mixtures multiple times a day, and he's never kind of faltered on that. And so we obviously are in a community where we talk to parents, and a lot of the conversation is around food and the meals. And we're very fortunate that Dominic will take his oil in that way, take his fat in that way. And so if you sat down to dinner with us, he would have heavy cream and oil, but his meal would look mostly like ours. And so he's been very accepting and very open to trying new things.
Yeah, and we've also anticipated, coming into his teenage years here are going to be very difficult for him. So he started seeing a psychologist that is actually on the ketogenic diet team at Children's Hospital of Philadelphia, who specializes in kids with rare diseases, epilepsy, and on the keto diet. So he meets with her a couple times a month just to talk about his feelings about stuff. And so we've anticipated it's going to be, a challenge, but confident we're going to get through it.
Yeah, one of the other things that, of course, that I mentioned is that, and I don't think Dominic is unique in this club. Looking at some of the other kids, he's a very he has my personality, gregarious and outgoing. And if you walked behind him in school, he's like the mayor, and we're very thankful for that, because that will get anyone reasonably far in life if you have good people skills. And hopefully that's just medicine's way of making up for other, kind of deficiencies that the genetic disease has dealt him.
Let's hope so.
Thank you. First, let me just again thank you, Dr. Korson and Nicole, and especially Tom, Maria. As Dr. Korson could echo on that one, is both are medical professionals. It's making the case even special to educate people. I have two questions. One is probably Tom, Maria, or maybe Dr. Korson can answer that one too. From your interaction with a lot of family, did you see if the treatment study at birth, for example, starting first week of birth, making how significant difference making for the sort of prognosis and the benefit? The point I want to say, if at any point to whether your foundation or other pushing for newborn screening for whether this disease actually somehow starting early in utero could be the process pathophysiology. Second, it's for the gene therapy. Could you elaborate for your foundation for the gene therapy? Are you consider some of right now we call the gene editing versus the gene delivery for the protein or transport is probably more challenging. See if you want to hear, Yale can help you actually foundation as actually we are working on the multiple sort of similar condition, use the gene editing, which is kind of one dose and fix everything kind of approach. I'll be happy to talk to you offline. So.
Yeah, so I'm just quickly, there are some researchers at Columbia, and there's a couple researchers, I think, in Japan that are working on early stuff with gene therapy. I know that the researchers at Columbia are running into issues with the vector, and they're also kind of running into issues with the mice model. So it is very, very early in the research stage.
Given that Glut-1 is such a rare disease, there's probably not many people doing kind of gene replacement therapy research specifically for Glut-1, but we're piggybacking off of the research that has been done for other diseases, cystic fibrosis, other things, which I think is pretty normal and natural. Related to your first question, I'm not sure if we have a critical mass to say that early intervention is making a dramatic difference. We hope that that is the case, and there are some companies out there that are have a good newborn screening tool, and there's some advocacy at some state levels to include that in newborn screening. I just don't think we have a critical mass to say that if you look at outcomes from those started on a ketogenic diet as an example, as a newborn, identified as a newborn, that their outcomes are going to be different. I think what I have seen is there's a dramatic spectrum of disease for Glut-1 deficiency, where we go to these meetings and there's some kids and young adults in a wheelchair that can communicate by computer only. And then there's Dominic, who's on the kind of less severe end of the disease spectrum, who is running around the pool, who you might not know who has it just because he's had so many years of kind of therapy and speech therapy, et cetera. So
and I would say, just from knowing a lot of families, that yes, there was actually a mother who had Glut-1 that was pregnant. They knew that the baby was going to have Glut-1 before the baby came out, and that baby, its first meal was a ketogenic formula, and that child is very normal or
less
typical,
affected.
less affected. So there are kind of these stories, but we don't have a lot of case studies. So we've just implemented a natural history study in the past 6 months. So we're hoping that we're going to start acquiring this information. And to go back to the newborn screening, we do not have an identified biomarker as of yet to be able to even lobby for it to be on the newborn screening. So there are a couple different researchers. Dr. Pasquale is looking at biomarkers along working with a Dr. Gentry, who's at University of Florida. And there is also a French company that is looking at it's called Metfora. They're looking at a blood test that would be able to red blood cell marker as a potential biomarker. But we're not there yet, but I am confident that we will get there. And I do believe that that early intervention into this does make a difference. It may not make as great of a difference for all patients, but just knowing, again, the 75-year-old woman whose life changed at 72 by implementing the ketogenic diet. It's pretty amazing.
Yeah, thank you. Yeah.
Well, actually, and just as a comment on the newborn screen, you have to remember that also most of the, if one wanted to take a molecular approach to newborn screening, most of the mutations in Glut-1 are spontaneous. So you're not looking for one particular mutation that might be representative of the most patients. So that's problematic. Another comment on there was a study in preparing for today of gene therapy in a mouse model, which showed that the Glut-1 deficiency can interfere with development of new blood vessels in the brain. And so the deficiency will actually arrest development of those blood vessels, which if gene therapy is performed early on, before 2 weeks of age, I believe, it prevented that arrest of angiogenesis. So early intervention seems like, theoretically, and maybe there's some proof that suggests that is in fact helpful the earlier you implement therapy. Additional questions. One thing I had is, so things trigger symptoms. So you mentioned when Dominic's ketones go down, you see the symptoms come out. Can you tell by looking at him whether his ketones are down?
Always.
Yeah.
All right.
And he denies all the time. Like, I'm fine, Mom, I'm fine.
We know.
I'm like, okay, you're not fine. But usually he'll just look like real tired. He'll start yawning a lot. He stretches a lot, rubs his eyes. When
He
they're
might drag his leg a little bit.
And it's not always related to his ketones being low. Sometimes he has these symptoms and his ketones are fine. His blood sugar's fine. He gets headaches quite often. He had one last night, and we gave him some Tylenol and Motrin and put him on the couch, and he knows that he just needs to go to sleep, and then he'll wake up and he'll feel fine. Sometimes he has blurry vision. So yeah, I can always tell. I can tell when his legs aren't working quite right, and he'll fine. I'm like, okay. But that's just the kind of child that he is. He does not dwell on his challenges. He just likes to push through them and not admit that anything is going on. So,
and don't forget, he is 12.
Yes.
And therefore, that's the other.
He lives and dies for his friends. That's what he wants.
Well, actually, one thing is, so certain situations are going to put him at risk. So excessive exercise, how does he prepare for a very busy, active day? Is there something he does differently?
I don't think he's intuitive enough yet to prepare that on his own. Yeah, we kind of do it. We make sure we have extra snacks with us that he doesn't do well with drinking liquids, so we have to kind of force him to drink a lot of water. He has had movement episodes when he's sick. Just being aware that that's going to happen and being a little more careful that he doesn't fall. Less of an issue as he's gotten older.
I'm sorry. Go ahead.
Yeah, we were in Disney, so it's a lot of walking every day. We worry about that exercise intolerance. So just being aware to take more frequent rests or not push him too hard.
Yeah, I can't carry him any longer. So, or it's harder to carry him for longer distances. We just make sure we don't put him in a situation where he's going to not do well, right? So if it's a really hot day in the summer, we'll make sure we do something near a pool or inside in the shade, because if we're up to him, he would just go, right? So he doesn't have that awareness as of yet, and so that's partly one of the things that we kind of are focusing on with him, not beating him over the head with it, but just making him aware of it.
Great, thank you. Any other questions?
But a lot of time, everyone's going to look at the chat. Of course, many people comments in the chat about how wonderful you all share the story. That's definitely.
Thank you for having us.
Yeah, we really appreciate you having us, and we're welcome to give this conversation and tell Dominic's story to anyone who is interested in listening, with the hopes of it may we may drop some breadcrumbs of our own, so that you might be able to care for your patients better if you come across a patient that may have this rare disease.
Well,
Right?
absolutely, yeah, absolutely. I think that your message, I know the journey you went through, part of the sort of at the end, it's amazing, but as frustration you experience the first 2 years, definitely it's a lot of educational for primary care physician, geneticists also too, and it's many we in kind of all this kind of similar situation again. So we just wish many people like you deliver the powerful message, and that and someday, some in the future, we're getting better and better for sure, compared 10 to 20 years ago. But we're not there for serving a lot of real disease patients the best so far for sure. A lot of logistic and knowledge and education and the testing, a lot of insurance even denied testing. For me, it's like, okay, your first year present seizure as a geneticist, if you come to me, I say, okay, everyone deserves a genetic testing. Who has some testing, right? Now you would find it very quickly, but then some insurance definitely it's not on that same reasoning as we do, but we have to push now, and your message definitely will help that push.
Thank you.
Thank you. And so, Nicole, do you want to say any final words?
Yeah, thank you so much, Dr. Korson, for sharing your knowledge on the disease and providing the explanation. And thank you again to Tom and Maria for sharing Dominic's inspiring story and your great knowledge on the disease as well. Rare New England would also like to thank again Yale New Haven Genetics Clinical Grand Rounds for being a part of our series today. And to learn more and keep up to date with Rare New England, please visit us at www.rarenewengland.org. And if you are interested in joining our mailing list, you can always email us at info@rarenewengland.org. So we'd like to thank you all for joining, and we appreciate you taking the time today.
See you next year.